So let's start. Today topic thyroid gland. A complete anatomy classes, huh? Thyroid anatomy complete. Physiology complete. Okay. So I am not going to discuss in details about anatomy and physiology in thyroid gland. So these are the topic we are going to discuss today. Disorder thyroid gland, biochemical test to assess thyroid function in laboratory, and some condition like pregnancy with high status, in condition like age, illness with some drug effect, about sick Euthyroid syndrome, lipid profile and thyroid status, etc. So please consider it here. So all of you know actually probably the Hypothalamo-Pituitary-Thyroid axis. You have already taught in physiology. From hypothalamus release one hormone that is called TRH, thyroid releasing hormone. Okay, and then this TRH from hypothalamus release TRH, thyroid releasing hormone. Then these hormones stimulate pituitary gland. The cells called thyroid releasing hormone, and then this TH is released in the circulation, and via circulation it reaches in thyroid gland. Then it stimulates to secrete T3 and T4. Okay, this is called hypothalamo-pituitary-thyroid axis. In the thyroid gland, we have thyroid follicles. In the follicle, we have these cells, and one multifunction enzyme is there that is called TPO, thyroid peroxidase. This is very important enzyme. It traps iodine, and then this iodine then go for organification with tyrosine amino acid, and then they produce monoiodothyronine and diiodothyronine, and then coupling occurs with these two molecules, and then forms T3 and T4, and sometimes reverse T3, reverse T4. Okay, this is a normal physiology actually. In some disease condition like autoimmune disease condition, sometimes develop antibody against this enzyme. That is called anti-TPO antibody, and then this antibody destroys this enzyme and causes hypothyroidism. It is called Hashimoto thyroiditis. I am coming later, just listen right now. So these are steps of iodine transport from blood into follicular cells of thyroid gland. First step is iodine trapping, then oxidation of iodine to iodide, then linking of iodine to thyroglobulin. That is called organification by thyroid peroxidase enzyme to generate monoiodothyronine and diiodothyronine. Okay. Then coupling of monoiodothyronine and diiodothyronine to generate T4 and T3. Then these hormones, endocytosis occurs, endocytosis peroxidase proceeds thyroglobulin. Thyroglobulin bind with these hormones, and when requires, this hormone release in circulation. Same thing written here. In the follicular cell, the iodine concentration is very high, so it have to enter actively. This is called iodine active transport. Okay, here you can see this hormone bind with this thyroglobulin, and then they store in follicle as colloid. This is normal physiology. We already read in physiology classes. Another important function of this amino acid tyrosine. Tyrosine required for thyroid hormone production. Now you can see first step is iodine trapped here. This is called iodine binding of this tyrosine molecule and form 3-monoiodotyrosine or MIT. Again, another iodine can attach with this 5' position also, 3 position and 5 position, and form 3,5-diiodotyrosine DIT. Then a coupling occurs with 2,3,5-diiodotyrosine bind to form 3.5 gram tetraiodotyrosine or T4. When inner deiodination, it causes 3.5 gram. That is called reverse T3. This is biologically not active. Okay, only 3 is active form, and 3 days, 5 days also biologically active form. Understand? Reverse T3 is not active. So this is the process of synthesis thyroid hormone T4, T3 and reverse T3. Understand everyone? Very easy. Then plasma transport. All circulating T3 and T4 hormones are bound to serum protein. That is called thyroid hormone binding protein. These proteins are thyroid binding globulin, transthyretin and albumin. Only 0.03% of T4 and 0.3% of T3 are not bound to proteins. These structures are called free T4 and free T3. These are actually biologically active. Okay. So in our routine practice, we prescribe for thyroid function TSH and free T4 in peripheral tissue. T4 convert into T3. T3 is biologically most active form and it is 3 to 4 times more potent than T4. Please remember, T3 is most active form. But in peripheral circulation, T4 is abundantly present. T3 is more active because it is not as tightly bound to serum protein as T4 and has a greater affinity to target tissue receptors. So please remember, these are the proteins, they transport thyroid hormones, thyroid binding globulin, transthyretin and albumin. Okay. Thyroid hormone, it has intracellular receptor in the nucleus. Okay. So you can see the free hormone, it released from the capillary and then it reaches in the target cell, enter into the cell and then bind with the receptor hormone complex and then it activates some gene. Then genes, they make messenger RNA. From there it produce its target protein, and then this protein causes various actions. Okay. So thyroid hormone has intracellular receptor. Effect of thyroid hormone. What does thyroid hormone does? What does thyroid hormone do in our body? It has multiple actions. In the cardiovascular system, it increases oxygen consumption, vascular resistance, increases cardiac output, increases cardiac contractility and cardiac mass. In the skeletal muscle, it increases oxygen consumption, increases protein synthesis, increases blood flow and increases contractility. In the liver, it increases protein synthesis and clearance function. In the kidney, it increases blood flow, clearance rate and vasoactive mediators. And all organ systems, it increases heat, thermogenesis occurs. Because it has receptor in mitochondria also. Okay. So one biological uncoupler is thyroid hormone T3. You have read in your electron transport chain classes uncouplers, right? So one example is T3 hormone. It increases heat, thermogenesis. Thyroid hormone increases BMR, basal metabolic rate. It increases metabolism. Okay. It has multiple actions in our body. Starting from normal growth, cell differentiation, increases heart rate, okay, cell proliferation, thermogenesis, reproduction, multiple actions. Very important hormone. Okay, let's see. Next slide. Symptoms of hyperthyroidism, very important. As you are MBBS doctors, going to be doctor, these are very important. All have to familiar with these symptoms, because right now if you visit in your home, sometimes your relatives may ask you, I have this kind of symptom, what should I do? Okay. So these symptoms are two types of symptom: hyperthyroidism symptom and hypothyroidism symptom. Okay, what are the symptoms? In hyperthyroidism, there is hyperactivity, because all of outtake the thyroid hormone causes increased metabolism. Okay, hyperactivity, irritability, and altered mood. Next is, as it is a physiological uncoupler, it causes heat production, increased heat production. So patient develop heat intolerance and increased sweating. In the heart, it causes increased heart rate, causes palpitation. Fatigue, weakness, is because metabolism very high. Weight loss, because in the adipose tissue, it increases fat breakdown. Okay, patient may develop loss of weight. Okay, it has caused a negative nitrogen balance in our body. In the GI tract, it causes increased peristaltic movement. So patient may develop diarrhea also. In the eye, in the retroorbital tissue, they may develop proliferation of retroorbital tissue, causes bulging of eyeball. This is called exophthalmos. Have you heard the name exophthalmos? Exophthalmos. Okay. So next time you found this kind of symptoms in a person, you may suspect this patient suffering from hyperthyroidism. Okay. What are the signs? Signs means as a doctor, you are going to, after checking this patient, you find this kind of symptoms, this kind of things in your patient. Sinus tachycardia. The next time you found this kind of symptom along with sinus tachycardia. Tachycardia means heart rate more than 100. Bradycardia means heart rate less than 60. Okay. So please remember, resting tachycardia is a very important symptom. Resting tachycardia. What is resting tachycardia? Patient is in quiet room, sleeping peacefully. Till then, his or her heart rate is very high, more than 100. This is called resting tachycardia. Okay. This is one very important symptom. Next is fine tremor. What is fine tremor? If you ask the patient to extend his arms like this, he may found his hands are shaking. This is called fine tremor. Okay, this is a very important sign, hypothyroidism. Okay, if you want to handshake with the patient, you may found his or her hand is very warm and sweaty. Okay, another important sign. Next is goiter. Sometimes we found patient is have one swelling over the thyroid gland. Goiter. Palmar erythema. This means redness of the palm. Palmar erythema because of high blood circulation. Okay. Onycholysis. Destruction of the nail bed. Onycholysis and itching. Pruritus. Sometimes pruritus. Alopecia. This means loss of hair. Alopecia. Okay. Alopecia. Muscle wasting, proximal myopathy. Patient may develop low, because this is a causes negative nitrogen ion nitrogen balance. So patient may develop muscle wasting. Eventually muscle weakness. So if you ask the patient to raise your hand and keep it for several seconds, you may find difficulty because of muscle weakness. This is proximal myopathy. Okay. And as I told earlier, exophthalmos. This is called protrusion of eyeball. So if you ask the patient to close the eyelids, you may find difficulty to close the eye completely. This is called lead leg. Portion of eye till visible after forceful closing of the eyelids. Understand? Lead leg. Sometimes found gynecomastia. This is swelling of the male breast. Gynecomastia. Chorea. This is abnormal movement. Chorea and periodic paralysis and sometimes psychosis. Okay. So this thing you have to remember. In the patient with hypothyroidism, we found this kind of symptom. Okay. Okay. So this is very important. There is I ask. Next, hypothyroidism. So these are the causes of hypothyroidism: Graves' disease, hyperfunctional nodule, that is autonomous adenoma, toxic marginal Goiter, iodine load with underlying Graves' disease. Sometimes in pregnancy, patient develop vomiting, excess vomiting, pathological vomiting. That is called hyperemesis gravidarum. Sometimes in case of carcinoma and sometimes pituitary adenoma. These are the causes of hyperthyroidism. Hypothyroidism. Please see the picture. Please make a imprint in your brain today. Patient with hypothyroidism, sometimes you may found in your life. Very common. Okay. Hypothyroidism is more common than hyperthyroidism. So what are the symptoms of hypothyroidism? So just opposite to the hypothyroidism. Patient feel tiredness, lethargy, fatigue, weight gain. There we have weight loss. Depressed mood, sad mood, cold intolerance, okay, dry skin, hair loss. The hair, there we have diarrhea and patient develop constipation. constipation, heart failure, hypercholesterolemia, there is high cholesterol in the blood, vascular disease, hoarse voice, and in case of female, menstrual irregularity and menorrhagia, there is excess menstrual blood loss. These are the symptoms. Okay. So when you check the patient, and here we have found these kind of signs. Here we have dry skin, thin hair, cold peripheries, puffy face. Here we see puffy face. Okay. Yellow skin, bradycardia. There we have tachycardia. Here we found bradycardia, resting bradycardia. Slow reflexes. Sometimes patient develop carpal tunnel syndrome. Okay, carpal tunnel syndrome. Sometimes patient develop serous cavity effusion. This is an extreme case of hypothyroidism. Myxedema. Okay, galactorrhea, ataxia, dementia, psychosis. Sometimes in extreme cases, patient develop coma. That is called myxedema coma. Have you heard the term myxedema coma? Myxedema. Okay, myxedema. So they are the sign you have found. This is a very common disease. Okay, hypothyroidism is very common. When you start practice, you can see a lot of patients suffering from hypothyroidism. Very common. Hypothyroidism. So hypothyroidism is very common. Please remember both the cases, hyperthyroidism as well as hypothyroidism, very important. Okay. Next, what are the causes of hypothyroidism? You can divide them two types: primary causes and secondary causes. Primary causes is very common is iodine deficiency. Okay. In the Himalayan region, mountain area, their iodine level is very less in the soil. So patient develop hypothyroidism because of iodine deficiency. Right now, government started adding iodine with the salt. So these symptoms now very rare nowadays. Okay. Next is autoimmune hypothyroidism. There is Hashimoto thyroiditis. As I told earlier, patient may develop antibody against this enzyme. That is called TPO, thyroid peroxidase enzyme. Sometimes patient develop antibody against this enzyme. That is called anti-TPO antibody. Okay. So when you are going to test this antibody, you may found high level of anti-TPO antibody. Then it is called Hashimoto thyroiditis. Please remember, Hashimoto thyroiditis. This is very common. Okay, Hashimoto thyroiditis. Next is iatrogenic iodine 131. Sometimes patients suffering from thyroid cancer. So sometimes they receive iodine 131, and this causes radioactivity and causes destruction of the thyroid gland, and eventually patient develop hypothyroidism. Okay. In case of cancer, thyroid, after thyroidectomy, patient develop hypothyroidism. Next is some drug that causes hypothyroidism like amiodarone, lithium. Lithium is an antipsychotic drug. Okay. Amiodarone is a is sometimes used for treatment of irregular heart rate. Amiodarone. Okay. This causes hypothyroidism. Sometimes congenitally absent thyroid gland causes hypothyroidism. Ectopic gland causes hypothyroidism. Okay. Sometimes TSMC receptor mutation causes hypothyroidism. Okay. Some type of inferiority disorder like amyloidosis, sarcoidosis, hemochromatosis, these also causes hypothyroidism. These are some primary causes. In secondary causes like tumors, trauma or surgery, infiltration or infection causes hypothyroidism, isolated TSC deficiency or irritability causes hypothyroidism. Sometimes hypothalamic disease like tumor or trauma also causes hypothyroidism. Okay, these are the causes of hypothyroidism. Okay, next, goiter. So this is the swelling of thyroid gland. Goiter, this is called goiter. Very common previously because of iron deficiency. This is called endemic goiter. Sometimes some agent causes goiter, and sometimes iron deficiency is not there till develop goiter. This is called sporadic goiter. Example: diffuse multinodular goiter, toxic multinodular goiter, Hashimoto thyroiditis, Graves' disease, destructive thyroiditis like postpartum or subacute thyroiditis causes goiter. Some genetic causes like dyshormonogenesis, thyroid hormone resistance, McCune disease, Albert syndrome, TC receptor mutation, these are also causes goiter. Inflammation like renal disease, amyloidosis, sarcoidosis also causes goiter. Okay. So in your exam you may found short note in goiter. Short note in hypothyroidism. So you have to write symptoms, signs, biochemical causes and treatment. Just like this, if you found hypothyroidism, you have to write signs, symptoms, biochemical causes and treatment. Goiter, so you have to write causes of goiter. This is a very big list, just remember something. Okay, next. Assessment of thyroid hormone function. To assess the hypothalamo-pituitary axis, test that measure concentration of various thyroid hormones in vitro. Test that measure impact of thyroid hormone on peripheral tissue. Test for evidence of autoimmune thyroid disease. Invasive test for histological examination. Gross abnormality are detected by ultrasound. Test that directly assess thyroid gland activity and integrity of thyroid hormone biosynthesis in vivo. So these are two things we have to assess when you go for thyroid function test. So what are those? First one is specimen collection. We collect blood in a plain vial. Clot tube is taken, although anticoagulant can be used. And specimen should be lipemic free or hemolytic free. Preferably to take a sample in the early morning. As I told in previous days, maximum hormone has diurnal variation. Okay. Thyroid also has some thyroid diurnal variation. So first our test is to detect TSH, T3, T4 measurement to see thyroid dysfunction, and second test is to know the causes of thyroid dysfunction like autoantibody, serum thyroid binding globulin measurement. So TSH, it is the single most sensitive, specific and reliable test for thyroid status. This is the reason TSH nowadays taking as to see screening of thyroid status. Sometimes patient come to you a poor patient You don't have to write everything. Just write one thing, TSH. Because this is the most sensitive and specific test. TSH. In primary hypothyroidism, TSH is increased. And hyperthyroidism, TSH is decreased or undetectable. Total T4, total T3, more than 99% T4 and T3 circulate in plasma bound to protein. Both T4 and T3 values change in thyroid gland globulin alteration, like in pregnancy. So free T4 and free TPD is nowadays using. Free thyroid hormones concentration are independent of changes in the concentration of thyroid binding proteins. This is the reason it is most reliable diagnostic marker to see thyroid function. Okay. So sometimes we prescribe TSH along with FT3 and FT4. F means free T3 and free T4. Other parameters for assessment like antibody against thyroid gland, like anti-TPO antibody, thyroid microsome autoantibody, thyroid globulin autoantibodies, anti-TSC receptor antibodies, thyroid globulin and calcitonin also. Sometimes we see thyroid function status. Normal range TSH, please remember 0.4 to 5.5 MIU per liter, microinternet unit per liter. Free T3 3 to 6.7 picomole per liter. Free T4 11.5 to 23 picomole per liter. Although this is defined laboratory, so please go for one standard textbook like Harrison. Okay. Right now, what your teacher taught in your particular classes, you follow them. These kind of patients sometimes develop thyroid problem, like patient history of thyroid disease or has strong family history of thyroid disease. Patient with autoimmune disease, other like or type 1 diabetes or celiac disease. Patient with dyslipidemia, with high cholesterol level. Those who taking some drug like amiodarone, lithium or interferon gamma. Past history of neck surgery or radiation. Suspicious thyroid symptoms like postpartum or as a previous episode of postpartum thyroiditis, chronic cardiac failure, coronary artery disease, elderly women more than 50 years old, menstrual disturbance, and some genetic condition like Down syndrome. So, this kind of question, if you found in clinic, just write thyroid function test. Patient with dyslipidemia, older female, more than 50 years old, patient has horsons of voice, patient has even hypercholesterolemia, patient has some other autoimmune disease. Okay, ask them to do thyroid function test. So TSH, as I told earlier, this is the most sensitive and specific marker. In hypothyroidism, TSH is elevated. Hypothyroidism, TSH is detectable, undetectable or suppressed. In sick euthyroid syndrome, normal TSH is being found. In pregnancy, normal TSH is being found. So interpretation: low TSH, high T4 and high T3. That is called primary hyperthyroidism. Example: Graves' disease, multinodular goiter, toxinodular goiter. Okay, you may found in case in your exam. So please remember these slides. If you found low TSH, high FT3 and high FT4, that is called primary hyperthyroidism. Okay. Next, low TSH, normal FT3 or FT4. This patient is taking thyroxine hormone, or patient is developing subclinical hypothyroidism. Subclinical means patient is having hypothyroidism, but clinically they have no symptom. Subclinical primary hypothyroidism. High dose steroids, inotropic infusions. If we found this, repeat this test after 6 weeks. Why 6 weeks? Because if you give them a patient with thyroxine, say patient develop hypothyroidism with high TSH. Okay. So TSH level have to come down, take 6 to 8 weeks. So wait at least 6 to 8 weeks before doing repeat test. Low normal TSH, low FT3 and low FT4. There is patient is having chronic illness, annual patient with non-thyroid illness, recent treatment for hyperthyroidism, secondary hypothyroidism like pituitary disease, congenital TSH or TRH deficiency or important to exclude hypoadrenalism. Okay. So if we found all the parameters are low, they may suspect the patient develop some other diseases. Okay. And also you have to exclude hypoadrenalism syndrome. If we found patient is high TSH level with low free T4 and free T3, that is called primary hypothyroidism. You ask the patient to see TSH value along with free TP and free T4. If you found high TSH value with low free T4 and free T3, that is patient is developed primary hypothyroidism. Next, high TSH is normal FT3 and FT4. Example is subclinical hypothyroidism. Patient is having hypothyroidism, but there is clinical no symptom. This is called subclinical hypothyroidism. Sometimes some antibodies, interfering antibodies, causes misleading of the result. And another causes are TSH resistance. TSH is there, so to see the result, if a TSH value is very high, so you may suspect TSH resistance. Please remember, subclinical hypothyroidism is also common. Subclinical hypothyroidism. Here you found high TSH value, not very high, but high, with low normal free T4 and free T3. Normal or high TSH, high FT3 and high FT4. This is actually misleading. You have to repeat this test. This is not possible actually. In rare conditions, TSH receptor mutation, TSH secreting tumor, anti-T4 or anti-T3 antibodies interfere with the assay, amiodarone treatments, psychiatric disease, familial dysalbuminemic hyperthyroid, sometimes hyperthyroxinemia will be found. Actually, in our practice, we found almost rarely found this kind of symptom. So remember two things at least: hyperthyroidism and hypothyroidism. In hyperthyroidism, there is TSH value is very less, where in hypothyroidism TSH value is very high. Thyroid autoantibodies frequency in the Hashimoto thyroiditis and GAP disease. Hashimoto thyroiditis, that means antibody, TPO antibody, we found anti-TPO antibody is very high. Sometimes actually we found, do this test regularly in our practice, and this is very high. 80 to 100% cases in Hashimoto thyroiditis is found this antibody, autoantibody, anti-TPO antibody is very high. In GAP disease, antibody is positive in 30 to 70% of cases. A thyroid autoantibody level can also be interpreted with a normal thyroid function test. There is TSH level. Okay. So in Hashimoto thyroiditis, we found anti-TPO antibody is very high, along with TSH level is very low. Very high, because patients come with hypothyroidism symptom. Here I found this value is high, with TSH value is high, with low free T3 and free T4. This is very common. Hashimoto's hypothyroidism, thyroiditis. Okay. Next, this is not so important. Just look at this slide. TSC receptor antibody. We do not do it regularly. Next is calcium assay to see the patient is suffering from medullary thyroid cancer. Calcium also is hormone is secreted from parafollicular cell of thyroid gland. Calcitonin. Why are you talking? Please stand up. No, you ना पीछे हाँ बोलो. What is Hashimoto hypothyroidism? बोलो আমি কি বলেছি এখন Hashimoto hypothyroidism. In Hashimoto hypothyroidism, what antibody you found very high? In Hashimoto hypothyroidism, you found anti-TPO antibodies very high. Please remember. Anyone tell me what is the function of calcitonin hormone? क्या बोलते हो भाई? What is the function of calcitonin? Calcium and very good. दाड़िये बोलो दाड़िये. ठीक है ना बुझते पारे ना. दाड़िये बोलते. दाड़िये जोर बोलो. दाड़िये बोलो हाँ जोर बोलो. Calcium regulation. Calcium and phosphorus. Please. Very good. Next. Pregnancy and thyroid function. In pregnancy, some changes occur in thyroid function. Hepatic TGP production is increased because of estrogen effect. Hence, total T4 increases but free T4 remains normal. Okay. SCG has weak TSH-like activity because of similarity in primary structure of free T4 and free T3 increases but TSH decreases as compared to pre-pregnancy level. Trophoblastic tumors like H-mole, choriocarcinoma are associated with high level of SCG and can cause hyperthyroidism. Okay. In pregnancy, we routinely prescribe TSH in all mothers because thyroid is very important for normal growth and differentiation. So, if the mother is suffering from hypothyroidism, so what will affect the fetus? Fetus will not grow, right? Fetus will not grow normally. So, to inhibit the bad effect of hypothyroidism in fetus, we do regularly thyroid function test in all mothers, pregnant mothers. So you may found a reasoning question. Thyroid function test done routinely in pregnancy. Why? Because some changes occurs in thyroid function in pregnancy. Serum total binding globulin concentration is increased almost 2 times because estrogen increases hepatic thyroid binding globulin production and TBG sialination occurs. This results in decreased TBG clearance, hence total T4 increases but free T4 remains normal. SCG has some weak TSH-like activity because of similarity in primary structure of TSH. Free T4 and T3 increase but TSH decreases as compared to pre-pregnancy level. Trophoblastic tumors like H-mole, choriocarcinoma are associated with high TSH level and can cause hyperthyroidism. Okay. You may ask 1 or 2 questions from this side also. 2 marks reasoning. Okay. Next. Thyroid function in newborn. TSH level is elevated soon after delivery but returned back to normal after 2 days. Serum T3, T4 and thyroid globulin concentration also increased to hyperthyroid range, lowered down by 10th postnatal day. Serum reverse T3 level increase but return normal by 5th postnatal days. Premature infants have immature hypothalamo-pituitary-thyroid axis leading to lower level of T3, T4 and TSH. So this is the status of newborn, the thyroid function. Next is sick euthyroid syndrome. Here thyroid related changes that occurs during systemic illness in the absence of intensive thyroid disease. Okay. Patients suffering from chronic illness may develop sick euthyroid syndrome. There you may found low TSH value, low free TB value, low T4 value. Because of reduced peripheral conversion of free T4 to T3, and there is decreased degradation of reverse T3, reduced production of thyroid hormone binding protein, increased circulating inhibitors of thyroid hormone binding proteins, and TSH is mildly elevated during recovery phase, which is reversed during acute phase. So in acute phase, there is you found low level of TSH, but in recovery phase, it may increase. Effect of thyroid function like dopamine, glucocorticoid. This causes depressed TSH, thereby causing decrease in thyroid function, thyroid hormone. Iodine preparations like amiodarone, lithium cause primary hypothyroidism as they impair hormone synthesis or release. Drugs which inhibit conversion of T4 to T3 include amiodarone, glucocorticoid, beta blockers, propylthiouracil, radiographic contrast agent. Okay. So this is the reason we used patient who suffering from hyperthyroidism. We give sometimes beta blocker like propranolol. Okay. Sometimes we give propranolol to inhibit peripheral conversion for T4 to T3 in case of hyperthyroidism. Are you sleeping? Are you sleeping? Are you listening? Okay. Okay, in hypothyroidism, we sometimes use beta blocker. The function of beta blocker is to inhibit conversion, peripheral conversion of T4 to T3. Okay. Sometimes in psychiatric patients, they receiving antipsychotic drugs like lithium. We use thyroid function test regularly. Next, hypothyroidism lipid profile. T3 is receptor in LDL. LDL has receptor T3. T3 causes increase in LDL receptor. Okay. So, patient suffering from hypercholesterolemia, we may found low level of T3 in the blood. So, hypothyroidism patient often suffer from hypercholesterolemia. Very important concept. Okay. Please tell me, one 38-year-old female has this complaint, palpitation, tremor, etc. Thyroid level very high. TSH is very low. Diagnosis? Hyperthyroidism. Very good. 56-year-old female, the feeling of tiredness, weight gain. T4 level is low. TSH level is high. Diagnosis? Hypothyroidism. Very good. 44-year-old female, tiredness, weight gain, thyroid level 14. TSH 8. Diagnosis? TSH 8. Hypothyroidism. Okay? Please go and read this topic, very important topic. Thank you.